1. This is Marianne Gandy. I'm part of the education team at the Association of Community Cancer Centers. I want to thank all of you for joining us for today's webinar, Patient Education and Engagement, Multiple Myeloma. This is part of ACCC's Transplant Treatment Path, Optimizing Patient-Centered Care for ASCT and Multiple Myeloma. And this is an educational initiative that's aimed at improving provider communication to optimize the treatment of multiple myeloma patients. Today we have Dr. Jo Kim joining us, and we will feature Lisa Merritt, Nurse Manager, and Kelly Lehmkuhl, Assistant Nurse Manager from the Arthur G. James Cancer Hospital and Richard L. J. Solove Research Institute at The Ohio State University. If you look at your webinar screen, you will notice that there is a questions text box located on the lower right portion. This is where you may ask the presenters questions throughout the presentation. You can type your question in the box and click the send button. We'll collect these questions and Dr. Kim will have them answer them during the Q&A portion at the end of the program. At this time, I'd like to turn the session over to Dr. Kim. Thanks.
Great, thank you, Marianne. And I want to thank Lisa and Kelly for joining us on this webinar today. As Marianne mentioned, this is an educational initiative that really started in 2014, and we'll get into some of the details. And it was really focused around improving the communication and management of patients with myeloma who undergo transplant. Before we get too far, I would like Lisa and Kelly to just give us a very brief introduction, as well as tell us what is your role within your institution. So Lisa and Kelly.
Hi, I'm Lisa, and I've been the nurse manager for our Hematology Oncology Clinic and Transplant Clinic for over a year. Previous to that, I was the assistant nurse manager, and previous to that, I was a clinical nurse for our myeloma team, and have been on that, basically in this arena since 2008.
And my name is Kelly Lehmkuhl. I am currently the assistant nurse manager of the Hematology and Transplant Clinic here at the James. Prior to that role, I was a clinic nurse for about 10 years prior to that, and also a bone marrow transplant inpatient nurse for about 7 years. So I've been in bone marrow transplant for about 17 years already. So it's a wonderful field, and it keeps growing, and I love what I do here.
Great, thank you very much. So this is, for those on the webinar today, this is our second of 3 webinars around this project that focus on multiple myeloma. And today we're really going to focus on the patient education and engagement component of what the project addressed. So let me just review the background and goal of this project. When patients with myeloma are being referred for stem cell transplant, there are opportunities to improve that process around patient education, engagement, care coordination. And ACCC developed this initiative to identify ways that those processes can actually be improved. This is funded by Celgene, and there was also a partner organization, the BMT InfoNet, that also helped collaborate and make this successful. And what we did is we went out to several different major transplant centers around the country. You'll see that we went out to Emory, GW, Seattle Cancer Care, and also the Ohio State University. And we invited several referring practices in the community to join us for these workshops at each of these transplant centers to talk about the processes, the way that patients are being referred, communication issues, and really spend some time identifying improvement opportunities at each of these places. And what you'll see is that before we actually started the project and conducted these workshops, ACCC conducted a survey. Some of you on the webinar may have received this survey because we wanted to really understand what are some of the strengths, challenges, and opportunities for improvement, whether you are an oncology referring practice, sending patients off for transplant, or whether you're working at a transplant center and managing these patients. And you'll see that within the top strengths, the referring practices really identified that their volume of myeloma patients, multiple myeloma patients, as well as their team of physicians and working together were some of the key benefits. At the transplant center, clearly, they have expertise in myeloma as well as access to a lot of trials. So there were some very common themes. As it relates to the challenges, the 3 points here listed on this slide were sort of universal in terms of the early recognition of toxicities and appropriate management, the patient compliance and adherence issues and follow-up, as well as the logistical, financial, and personal barriers, especially when patients need to travel to the transplant center and go somewhere that's new to them. So in terms of some of the ideas and opportunities for improvement that we identified, the referring practices and the transplant centers both recognize the need for better communication, both verbally, written, electronic, and we'll get into some of those details later. But also with the referring practices, the need to better educate and prepare patients so that when they actually get to the transplant center, they're better equipped and know what to expect in that dialogue. The project did certainly focus around the Centers for Medicare and Medicaid Services quality strategy goals. So CMS has sort of outlined these 6 strategy goals around quality improvement. And you'll see that number 3 on the lower right, promote effective communication and coordination of care, was one of the main ones that we really wanted to highlight in this project. We know that the transplant centers clearly have the clinical expertise, the scientific knowledge. However, when it comes to communicating with the referring practices, and when the referring practices are preparing medical records and sending them off, scheduling appointments, there's a lot of logistical opportunities for improvement from both parties. And so getting them together into the same room, having these open discussions and dialogues was really the first major step in sort of uncovering and unraveling some of those key opportunities. So when patients are referred for transplant, and there's a whole process obviously around the preparation, as well as when they undergo the active transplant process, and then post-transplant when they go back to the referring oncology practice in the community and then have long-term follow-up. And these were sort of the 3 dimensions that we discussed during the workshop, as well as when we followed up and sort of talked to the various organizations and then drafted an article. We really wanted to identify what are the opportunities here for improvement. And today, focusing really around educating, empowering, engaging that patient from the preparation stage as well as through the transplant process, and then when they're being discharged from transplant, whether they received the transplant as an inpatient or whether they underwent transplant as an outpatient, making sure that they're properly educated and equipped so that the follow-up process also occurs smoothly. So these were some of the key points that we focused on. And one of the tools that's used at the James is this question and answer sheet, and it's part of a larger tool, a patient education binder. And so at this point, I would like to invite Lisa and Kelly to just share with us a little bit about the process that you all use in terms of the patient education materials and how tools like this question and answer sheet are actually used within your organization.
This is Kelly. So yeah, we developed a binder probably about 10 years ago, and it was very generic at first, and it was kind of the nurses on our unit developed it. And then as we got patient education and the department involved, we developed a whole binder of a multitude of information, all about the central line that they get, about the actual transplant, symptom management, what to expect in terms of emergency care post-transplant and who to call. And then again, with this sheet, the blood and marrow question and answer sheet, this is something that we encourage patients during our education session to pull out and write down questions and or afterwards, because a lot of times when you go to see a physician or a doctor, you think of questions after the fact. So we always encourage them to write down their questions, and then they can contact us or their bone marrow transplant coordinator to get the answers to the questions that they have.
Great. And in your experience, have you found that most of the patients are coming in with a lot of questions written, or are there sort of common questions that you're seeing over and over?
A lot of them are common questions. It's things that they think about after the education session and they forgot to ask. But yeah, they definitely reach out to our triage line for answers as well as the BMC coordinators.
And just let's spend a minute talking about the actual education session. Is it a single day, a 2-day event? Like how much time do they actually spend and who do they talk to when they're receiving the education?
Well, it is a 2-day workup process. Usually the first day consists of testing, heart testing, lung testing, all those key things that we want to focus on. They also see a bone marrow transplant coordinator, and they go over the consent forms at that time to really know what to expect during their transplant. They will see a social worker, and we definitely evaluate the psychosocial aspects of the patient and the resources that they may need either during transplant or post-transplant. They will see the physician, the nurse practitioner for the health and physical assessment. They then will go to an education session with one of our nurses, and each of the nurses in the clinic are versatile in teaching that class. We have a dedicated class every day, and it's about an hour-and-a-half class where we're teaching them how we actually collect the stem cells and the medications we use to help collect the stem cells, and then as well as the actual transplant process and how the transplant goes and what to expect in terms of side effects from the transplant.
Great. And I know that at the James, you all still do transplants as an inpatient. Is that correct?
Correct, yes.
Okay, great. Well, thank you very much for sharing that. We'll sort of dive into some more specifics. Let's just move on. Another example that came from the Seattle Cancer Care Alliance, which was one of the participating transplant centers. They also have a series of materials and documents that they also provide their patients. And one of the resources, just sort of highlighting an example from their resources, is sort of the step-by-step, sort of, outlining step 1, step 2, 3, 4, and so on, with the fact that, number 1, at Seattle Cancer Care, they do their transplants as an outpatient, and number 2, given sort of their geography in Washington, they have a number of patients who have to travel for many, many hours just to get there, and then the long-term follow-up might really be just within the primary oncology practice. They may not necessarily travel back to Seattle that many times. So just geographic constraints and indications, but also some ways of just really preparing patients by really clearly outlining the specific steps along the way. The theme of shared decision-making came up over and over in this initiative because we certainly know that today, particularly in the landscape of oncology care, it's becoming more and more important to involve the patient, to really get them educated and engaged. And so this process where there's been now a number of different articles written in the literature around the application of shared decision-making in oncology care is really 6 primary steps where you invite the patient to participate, you present some options in terms of the clinical and medical options available to them, talk about the benefits and risks, and then guide them in this sort of process and implement the shared decision-making steps. So in terms of the actual rationale and the benefits behind shared decision-making, we know that particularly today, cancer care is very complex. There are many treatment choices, and in some cases, the evidence behind those options are limited or incomplete, or in some cases, even controversial. And so by involving the patients, they can have greater confidence, as well as better satisfaction and greater trust in their providers. But we also know that there's a real time barrier, and not every provider, whether it's a physician or a nurse, is really equipped and trained formally in this process. And some patients, depending on their framework and their sort of generational mindset on medical treatments and medical decision-making, may have some anxiety, or they may have misinformation or lack of information. So there clearly are a number of ways to just overcome this process, but I think equipping and making sure everyone is knowledgeable about shared decision-making is an important part of oncology care. I guess I'd like to ask at this point, Kelly and Lisa, within your organization, how would you describe the application of shared decision-making process as patients are introduced to the concept of transplant and as they weigh the pros and cons and decide on how they should make that decision?
Hi, it's Lisa. I would like to say that being in first new patient consults the first time they come for their myeloma care, the physicians and our advanced practice providers do an excellent job in really feeling out what the patient's options are right from the beginning. Many treatments we know can negate any kind of transplant. Other treatments are augmented with transplant, so it's exciting to kind of watch their process from the beginning, engaging the patient in what their overall goals are, what they're very good at kind of ascertaining what they've been through and what they're willing to still go through. We do offer a lot of clinical trials, so I feel like because of that environment where clinical trials is such an important decision on whether or not you're going to allow yourself to endure maybe a little more, a little extra, they're very good at explaining those risks and benefits up front, and really kind of, along with the nursing staff, helping the patient understand, okay, what did they just tell me? What are my options? So I feel like it's a high level of engagement right from the beginning.
That's great. Yeah, I know that when we conducted the workshop there was a lot of discussions just around how much time the transplant physicians spend with these patients. And I would say wherever we went and conducted these workshops, that's kind of a universal theme and thread that comes up over and over, that really that time in educating the patient, really counseling them and presenting them with the options is really critical. And certainly for a number of the sort of community-based oncology practices where they're not performing the transplants right there, they may not necessarily have the time and the luxury to really sit down to discuss these things with patients, which sort of leads us to this next slide that talks about some of the available tools and resources that are out there. We know that clearly there are a number of organizations, both local, international, regional chapters, that have developed printed materials, electronic materials and resources. There are so many different tools out there that are used by patients themselves, as well as by clinicians during that sort of shared decision-making process. And yet, at the same time, given that what a transplant center may offer might not necessarily be reflected in a specific document, during these workshops, we discussed the opportunity to develop a common educational resource. And the idea here was that if most of the referring practices in a certain geography are primarily sending their patients to a single transplant center, wouldn't it make sense to have that single transplant center develop their own customized patient tool, not a very sophisticated and extensive tool, and they don't necessarily need to recreate the wheel that these other national organizations have developed, but something that just can be a common example and a common tool that once again helps these referring practices, so that when they say, hey, I want you to go to such and such an organization to be considered for transplant, they've got something that the referring practice can actually hand the patient. And with that in mind, I know that the James developed this tool, and it was just sort of a single page back and forth that's then folded up. And at this point, I'd like Lisa and Kelly to just share with us what was some of the thought behind this tool, and how do you envision organizations might use something like this, primarily from the standpoint of these referring practices who are sending patients to you?
Well, I know that our program has done a lot to reach out to our referring physicians out in the community to let them know what types of transplants we offer. The physicians work collaboratively with these referring physicians and offices as well to help educate those offices on what we do here. We not only developed this handout, but we also have a handout for patients as well that we provided in our hematology transplant clinic to let them know about the things that we want them to look out for and the services that we provide to them.
Great. And I know that this idea of developing sort of a common tool, something that's branded to a specific center and that can be sent out to referring practices, was also an idea that was well received by the referring practices, because they then have something that they can, once again, hand to the patient, sort of walk them through without spending an exhaustive amount of time with the patient. But it also prepares that patient so that when he or she arrives at the transplant center, they've at least been introduced to some of these concepts, and they're better equipped and better prepared. I know that you all spent some time discussing your patient education class. Another example from Seattle Cancer Care comes from the education class that they developed, and within their organization, and maybe it's reflective partially by the demographics of the patient population there, but they also really encourage the use of social media, video libraries, as well as they have some weekly online classes. And even within their printed materials, like the Transplant Resource Manual, they'll say, hey, visit us, find the Patient and Family Education on Facebook, and there you can sort of get engaged with some of the members of our transplant team. So I guess for Lisa and Kelly, within Ohio and sort of the demographics of your patients, what's been your experience using digital media, social media, electronic media to educate and engage patients?
This is Lisa. I would say that we're making strides to provide that level of education to our patients that are wanting to get a little more of their information online. We have had some partnerships with our patient education department here at the James, where they have put a lot of the older print materials easily to access on some patient education sites. So it's sort of a two-part process. As they develop those resources, I think it's up to the staff to be good stewards to promote those so that our patients get a good idea of what's out there. And I notice at times when we know that patients are looking at different resources, we will try to guide them to the more appropriate resources, because there's a lot of there are a lot of unauthorized resources out there on the internet that can give them some information that may not be the type of information that we want them to receive, that is something that we advocate for. So we try to guide them with those resources and make sure that they're getting the access to those types of things. I have to say the social media aspect with the Facebook and that type of market, I think, is still an opportunity for us here at the James. We have a website, but it's not something that I know of that people are accessing as much as it probably could be.
Sure, and we certainly understand that, and that's been, I think, reflective of this project as well, when we visited different geographies and asked the organizations about the various patient demographics within those regions. And even within those patients and the family members, what are the expectations in terms of how they're communicating? For instance, are they using patient portals? Are they relying on a lot of digital communication? Or is it still largely phone calls and mailed letters? So I think those are elements that, like you mentioned, continue to evolve. And I think there are always going to be growing opportunities to explore new ways to leverage these kinds of technologies. And so that was a component of this project. Another major component that came up was just identifying the caregiver and the caregiver's responsibilities. And so this is just another example from one of the resources where it actually gives you some very specific examples of, if you're going to undergo transplant, you need a caregiver or perhaps a couple of different caregivers. And these are the actual roles and responsibilities. Now, I know that often with the patient education courses that are developed, the patient comes with a caregiver, most frequently a family member. So once again, just asking Lisa and Kelly, within your organization, when you're educating the patient, and if you have a caregiver there as well, how are you outlining the various caregiver responsibilities and making sure that the caregiver is properly educated and equipped?
So one of the major, I guess, issues sometimes is that a patient doesn't have a caregiver. And in terms of, especially with our allogeneic population, they have to have a caregiver identified. And we work with our social workers where they meet with the patient for a complete hour, and they want to make sure that those resources are available and that they feel that the caregiver is confident and able to provide the care that's required after transplant, because it can be complicated managing medications, central line care, appointments and things like that. So that's a huge aspect. And our transplant coordinators, as well as the social workers, actually do a transplant evaluation, and it's a score, and they rank the score of the patient in terms of their psychosocial issues and things like that, as well as the caregivers and their ability to take care of the patient. In our PowerPoint slide / education session, we do have a whole slide, and we talk about the patient caregiver's responsibilities in the care of the patient. And again, that is addressed with the physician if there are issues that arise with that. So it's definitely addressed. It's a very important aspect of the patient's care.
Now, it's a great point that you mentioned that these different issues are scored. And so when they're scored, and if you identify what I would call red flags or issues that need either proactive assessments or some interventions, how is that handled within your organization? Like what happens to the scoring information? What kinds of interventions are then deployed?
Well, the physician team, as well as actually the multidisciplinary team, meet every week during a census meeting, and they review all the upcoming admissions. And they review all those scores in terms of comorbidity scales and what they call the TURIS score, which is the transplant evaluation rating. And so everybody within the room kind of makes a decision sometimes, because unfortunately there's times when it may not be appropriate to do a transplant on a patient that has a very high score, due to either psychosocial or comorbidity scores. So a lot of times that's a unified decision based on the whole team, whether we feel like we can safely transplant that patient or not. So again, we just meet and we discuss that, and we work with, again, social workers that help us identify other resources that we could possibly use to help care for this patient.
Great, thank you. I know that you also mentioned in your comment that a lot of these patients come, or some patients come, and they haven't identified a caregiver, and that was a common theme that came up in many of these workshops. I think the referring practices, when the medical oncologist suggests undergoing transplant to these patients, they weren't necessarily spending that time to suggest to that patient, hey, by the way, if you do go for transplant evaluation, you also will need a caregiver, and these are some of the roles and responsibilities of that person, and it would be beneficial if you went for that evaluation with a caregiver if possible. So we did spend some time discussing those opportunities as well, and making sure that the referring practices really bring up this issue so that it's at the front of their minds of the patients, and hopefully when they sit down and actually go for that initial consultation, they're once again better equipped. So these common themes, I think, came up all throughout the country, and these were very important elements where, once again, having some proactive steps of communication in place really hopefully will lead to some improvements. So speaking about improvements, the model for improvement in quality improvement in healthcare, one of the very basic and fundamental ones is the Plan, Do, Study Act, or PDSA cycle. Some people refer to this as the Plan, Do, Check Act, so PDCA cycle. And it's widely adopted. The Institute for Healthcare Improvement endorses and really encourages the use of this model because it's very simple, but it's also very structured, where you plan the intervention, you carry it out, you study the impact, and then you decide whether you're going to change that plan or scale it out to a more broad sort of application. And so at every workshop that we conducted, we left the groups really considering, okay, here are some ideas for improvement, here's some possibilities. Now you need to follow up and sort of regroup and fill out some of these PDSA worksheets, where you have to very clearly specify the change and make it really specific, as well as identify who those people are going to be who will be responsible for overseeing those changes, measuring the impact of those changes, and then assessing whether or not it really did what they intended it to do. A lot of team-based sort of care, team-based approaches, and these PDSA worksheets were really instrumental in, once again, guiding some of the improvement ideas. So using the example of sort of that common education tool that was developed, it wasn't just a single person effort. It was really a team-based effort, and it required that team to assess the impact. Some other examples for improvement revolved around just communicating with the referring doctors in the community about the various clinical trials, the enrollment criteria, the inclusion and exclusion criteria, and so forth, so that that information is more readily accessible to those referring oncologists. So there were just a number of these kinds of examples. We use this as really that basic framework to make some improvements, and we believe that it really did lead to fundamentally some very basic ideas on how to improve communication, once again, between the referring practice and the transplant center, both before as well as after transplant. So as we get ready to sort of wrap up and get ready for the question and answer portion of this webinar, I'd like to just remind everyone on the webinar that if you have questions, you can type it in to your webinar chat box. We've already got a few questions coming in. We will do our best to answer as many of them as we can. And this, as a reminder, is the second of 3 webinars. So the first one already occurred last month. It's been recorded and it will be available on demand. This one also is being recorded. It will be available on demand. And then the third one is coming up in a couple weeks. And this project around myeloma really allowed us to, once again, get multiple stakeholders in the room to identify those opportunities for improvement. And then it led us to follow up and see what the impact was, using the PDSA cycle and that framework and really measuring the changes. I think for many of these organizations that already have an ongoing culture of continuous improvement, this was yet just another project that they could sort of put into their portfolio. But for some of the smaller organizations, particularly the referring practices, some of the outpatient oncology practices, and some of the smaller community-based hospitals that do not perform transplants, for many of them, it was an opportunity for them to get involved and engaged in a formal quality improvement sort of process and undergo some of the steps and just to embrace that culture of looking for ways to continue to improve. So for those on the call, if you're interested in learning more about this project, there is a under the ACCC's website, under Provider Resources, there's a Transplant Treatment Path Communication Guide that was also mailed out with oncology issues, but it's available for download on the ACCC's website. And at this point, I'm going to start getting into some of the questions that are coming in from the audience. So the first question deals with health literacy. How do you, Lisa and Kelly, assess patients for health literacy, and do you tailor your educational approach based on the health literacy? So can you comment on that?
This is Lisa, and I would like to say we do assessments when they come in for their first visits, and it's part of our physician physical part. I'm sorry, I'm at a loss for words. They do assess part of their education that they've had ongoing, and I think a lot of our education we have already had tailored by our patient education department for an 8th grade level. Mm-hmm. We are very strict about keeping it at the lowest level so that we can reach everyone. The second piece to that is then as you learn what specific realm of opportunity you have for that patient based on where they're at, we are trying to look more at having more specific resources based on different levels. It's something that we haven't put into production yet, something that we just as a unit have been talking about, and the fact that we get so many diverse referrals. We can have everyone from the true 8th grade education to postdoctorate patients, and how do we meet their needs. And so part of that, assessment is huge, and that begins at the first visit.
Sure. Thank you. Yeah, it's a great point. Another question that's coming in now is around the issue of educating family members who maybe missed that class or not able to attend that class, and then these family members have questions for the medical team. How does your team sort of educate the other members of the family in this process, in this journey?
Yes, a lot of times we do have family members call into our triage line, and they will leave messages for our primary nurses, where our primary nurses can contact the patient or family member back to answer the questions. Oftentimes, though, if the family member has not been able to attend the class, we encourage them to come back, because we do hold classes every day, and we encourage them to come back and join the class so that we can properly educate them. We also, at the time of admission, obviously, a lot of that information is all reiterated, and then the caregiver information is provided closer to discharge and kind of the responsibilities of what that caregiver needs to be able to perform when the patient goes home.
Okay.
And I did want to mention on a comment back to where Lisa was in terms of literacy, we do see a large population of Spanish, Somalian, and other different ethnic cultures, and we work with our interpretive services department to help make sure that the patients that do not speak English are able to understand what they're going through and things like that. So we also often have interpreters available to go over information.
Now, have you taken portions of your binder and translated them into different languages at this point?
At this point, we haven't. There are some of the other documents, especially the BNC consent forms, that have been translated into their home language.
Okay.
But some of the content of the BMT binder has not been translated at this time.
All right. Another question that came in is just regarding the discharge process and patients in terms of the follow-up and the education that they need at that point, you know, survivorship, social support, support groups. What kind of sort of follow-up education do you all provide at discharge and then even after discharge? And you can talk about both, I guess, the education as well as any kind of social support or support groups that you all offer.
For our myeloma patients, we have we work a lot with our local oncologists and referring providers, because a lot of times the follow-up process, they may have a few visits with us after their transplant, but then they get referred back to their local care because of the mileage that they're traveling, and they want to receive their support locally. So we do partner with our local oncologists to help provide the necessary resources with the patient education that we have. We've been working on some survivorship that have been rolling out to our transplant and our allogeneic transplant folks as well, that covers a lot of the basic social work needs that tend to happen, and the psychosocial issues with the psychologist. Those are things that we assess when they come for their follow-up visits, as well as providing a new survivorship clinic for those transplant patients. And what happens in those visits is that they're referred at 90 to 100 days, and then at 180 days for their traveling through their whole first year of transplant, so that we can make sure that we're identifying those extra needs. Are they getting the caregiver support? Are the caregivers getting the support that they need? Are they able to just get their medications that they need to follow up on? That's part of their standard of care after transplant. All of these things are identified. The second tool that we use is a psychosocial assessment. That's a supportive care screening, and that is done in the hospital before they're discharged. So it also helps us to know on a larger basis what types of things to expect that may come up for each patient. We're all different. We all come from different backgrounds, so what one patient may struggle with, another may not. We have some definite continuities, kind of what you described earlier with a high anxiety. We know that the treatments will last for so long, so we have a triage phone line service that we offer, and I would say it averages about 500 calls a month where we're able to have them call into a nurse and get advice on anything from colds to managing complex care needs, like they're referred to get care urgently because of what they're calling in for. So we try to provide those things as well.
Mm-hmm. So that leads me to ask another question regarding that triage phone service, because in some of the other webinars we're talking about the whole co-management between the referring practice as well as the transplant center. If patients are calling that phone triage service post-transplant, is the information that's being discussed being then somehow captured and shared with the primary oncologist in the community, or how is that responsibility placed on the patient, or how do you all sort of work through the co-management part of that?
I would say that it's probably mostly placed on the patient to relay that information. When we refer a patient to be seen locally instead of coming back to our facility, we do a handoff with that facility and that physician's team. What we are noticing is the amount of coordination of care between these just little calls in between actual patient visits has grown so much that we actually have a work group that we started a couple months ago that kind of captures a little more of how do we coordinate this care for we document everything in our electronic medical record, but does the referring physician have access to that medical record? So are we all online on Epic, or do we need to go to DocLink or some of these other programs that allow a little more transparency between the referring physician and our center, and then how do we manage the consents behind those things. So we've kind of tagged it as a virtual medicine work group, and that's what we're trying to really coordinate, is how do we expand this huge continuity of care issue so that everybody is kind of up to speed in real time on how our patients are proceeding.
Great,
Yes.
Go ahead.
I was just going to say we try to tie in as much information as we can within their, when they come to see the physician, and of course those notes are shared, but in between it really does become a challenge.
Yeah, no, thank you very much, because the third and final webinar that we'll be holding on December 17th really does focus on this whole co-management issue, ties into all of the issues that you're bringing up, like access to patient records post-discharge and the whole communication between the referring physicians as well as the transplant physicians and that whole team. So I think you're sort of giving us a preview of some of the things that we'll be talking about in a few weeks. Just one other quick question that came in, which is around that question and answer document that you encourage patients to fill out. What are some of the most common questions that you're seeing that are not already being addressed by sort of established FAQs, if you will, the frequently asked question portion of your education materials? Can you give us a sense of some of the questions that maybe patients come in with that are really specific, that are probably not going to get addressed by a sort of pre-printed FAQ document?
A lot of it, I think, there's so much anxiety when it comes to when there are visits here. It's a 2-day process. There are long days, and a lot of times they just don't absorb the things that we're obviously always reviewing in the patient education course. So a lot of it revolves around the actual transplant and what to anticipate, the symptom management. Sometimes they hear things and it worries them, and then they're like, oh, well, what about this? So often we get calls, or the VMT coordinators will get calls afterwards just to clarify the information provided. Like anybody, when you're anxious, you just don't retain the information that you need to. So a lot of it's just more reiteration, or maybe just a clarification that patients need to feel more comfortable regarding the transplant process.
Okay, great. Well, at this point, we are at the top of the hour, so just a reminder for all the people on the webinar that if you go on the ACCC's website under Provider Resources, there's the Transplant Treatment Path, which is a communication guide for the multidisciplinary team. And with that document, you'll learn more about this project. Keep in mind that this is the second of 3 webinars. There is a third webinar coming up, and if you missed the first one, you'll be able to access the archive webinar also on the ACCC's website under Provider Resources. Look for multiple myeloma. So thank you to Lisa and Kelly for joining us and for your comments today. Thank you to all the people on the line, and at this point I will hand it back off to the people at ACCC.
Great. Thank you, Joe. Thank you, Lisa and Kelly, and thanks to everyone for joining us. This webinar will be available by the end of the month.